Good afternoon. Time you see this, it should be Saturday. Um, it's a great honor for me to present at this conference, and especially on this topic of management of large acoustic neuromas. I'm David Haynes. I'm a professor of otolaryngology, neurosurgery, and hearing and speech sciences at Vanderbilt. It's a big topic, obviously, and I'll only be able to hit some of the high points. But as I put this talk together, I thought I would kind of go back to the way, if you will, when I first started my career. I finished my fellowship in 1994. And so I've been at this now 30 years. And I've done a lot of surgery. Much of my career was not spent doing research or administrative work, but a lot of surgery. But it's interesting to see just how much has changed in that 30 years, just in my career. I'm not talking about a historical analysis of 100 years, but just in my career, and I'm still operating. But in 94, everything was a complete resection. There was really no consideration for conservative management. There weren't that many MRI machines, and so access for follow-up was impaired due to this relative lack of MRI technology. There was really poor understanding of growth rates. We're early in the stereotactic radiation techniques and experience, and I think we really, probably more than anything, had a poor patient-centric understanding of what outcomes were important and which ones were unimportant. I was even thinking in this era of how often we did 712 anastomoses and intraoperative anastomoses, and really things that we rarely do now. There's this one paper I remember writing as a resident, published when I was a fellow, on the natural history of untreated acoustic neuromas. There were 50 patients in a 15-year observation, and as you read the paper, every one of the patients had were followed had a reason. They were ill or on blood thinners, but there was really no. It was almost apologetic that we were watching those patients and not operating, because operating was the thing to do. Everyone had a very specific reason to not operate, and none of the reason was just because we thought that was in their best interest. And that was at the beginning of my career. Now we are much more tolerant of a partial resection. Really, conservative management is becoming more and more favorable. There's increased MRI access, which facilitates conservative management. We have a better understanding, but not complete understanding, of growth rates. Really, there's improved radiation techniques and high-dose radiation technology, and improved experience with our colleagues in radiation oncology. And I think, importantly, we have a better patient-centric understanding of the outcomes and a very low tolerance of complications, including even a low tolerance of a mild facial weakness. I put a question mark next to improved surgery techniques, because I really don't know if they're that much improved. Back in the beginning of my career, we had microscopes, we had ultrasonic aspiration, we had laser, of course, all the microsurgical technology and instrumentation. Better microscopes perhaps now, but we had facial nerve monitoring. So I don't know if the surgery techniques are better now per se. I think what's really the biggest thing that's changed is a better understanding of what's important to patients. We do have better multidisciplinary teamwork and communication. We've never, as a center, really been in favor of staging large tumors. That is, we don't really have no problem with it for other centers, but we've not said debulked tumors via a retroseg and then followed with a translab or vice versa. We just considered that to be two operations, and didn't find the value in that. And our seventh nerve rehabilitation techniques, when needed, are very different. Using Botox, we didn't use 30 years ago in cross-facial nerve grafts. Tumors now are initially even observed, as we don't know, and say someone who's in their 50s or 60s, how long that's been there. We know from growth rates, the tumor could have been in there and growing for up to 30 years. We look for edema. We may observe it for a short period of growth, although maybe not on this size on this slide, but for a moderate to moderately large tumor, there's not an emergent or urgent need for surgery in the lack of edema or symptoms. We plan to remove the tumor when surgery is scheduled completely, but we make intraoperative decisions to determine if a subtotal resection is needed. And then the residual tumor, early when we started doing subtotal removal, was radiated. Now, after periods of observation, we watch the tumor, as we know that all these tumors don't need stereotactic radiation after surgery. We try to take as much tumor out as possible and try to devascularize the remnant as much as possible, and use a patient-centered thinking approach, especially intraoperatively when we're making decisions. The real question is, of course, if we decide to leave a small amount of tumor to preserve a ventral area where the nerve may be compromised or stretched, like we see here, what's going to happen to that tumor? What's going to happen to that remnant? Will it mean more surgery for the patient? Will it mean that we have to radiate? Will it grow? What rate will it grow? And those are questions we've all had and questions we've tried to answer. We did look at this. Here's a paper we wrote just a few years ago. We looked at our surgical series from 2008 to 2019. There were 385 total cases. Most of these were moderate to large tumors. We did gross total resection in 236, near total in 77, and subtotal resection in 71. The single predictor analysis, which was associated with risk of regrowth or salvage therapy, is tumor volume, ventral extension, and subtotal resection. The multivariate analysis favored only subtotal resection. And surprisingly, we found that the absolute remnant volume and extent of resection did not predict regrowth. Subtotal resection, of course, had larger tumors, brainstem compression, and especially larger ventral extension. The age, the patient's weight really had no effect on decision making. There were 78 recurrent tumors, 3% of the gross total, which is defined as no tumor visible during surgery and post-op. Near total is where we know we've left some, but we can't see it on the tumor on the post-op imaging. And we scan people the day of surgery or the following day. And of course, all of the subtotals had remnants of tumor. Of the 78, 69% grew, 7 or 9% were stable, and actually 17 or 22% regressed in size. Of the 71 subtotals, 37 had some post-op growth. But this is the really key part of this study. Only a small proportion of the cases required salvage radiotherapy, and none have grown since salvage radiotherapy. So only 4% of the near totals and 15% of the subtotals who grew and were radiated required radiation, and none have grown. This is a Kaplan-Meier plot where we looked at survival free of salvage therapy, which is very favorable, and survival free periods of tumor growth, also favorable, knowing that only 4% underwent salvage therapy with no further growth to date. So our conclusion, it helps strengthen our strategy of subtotal resection. It remains a viable option for large tumors. We feel that tumor biology plays a role in predicting growth, and that predicts the variability of the growth that we see. But surprisingly, absolute tumor volume and extent of resection was less predictive of regrowth than we previously had felt and believed. And subtotal resection is effective in salvage therapy in controlling regrowth in those rare cases where that's needed. We looked at a couple other things since this is a talk on management of large tumors. That we looked at our CSF leak rate, tumor volume, and body mass index were not associated with increased tumor or CSF leak in this recently published paper that we found interesting, but sigmoid sinus thrombosis was associated with an increased chance for CSF leak. We also looked at predictors for increased length of stay in cases performed between 2008 and 2019. Surprisingly, preoperative tumor volume did not increase length of stay as much as we would have expected in a multivariate linear regression model. Preoperative tumor volume was far less of a cause for increased length of stay relative to coronary artery disease, high blood pressure, and any other major complications. So basically, barring any additional complications, that large tumors do not have a significant effect on length of stay. So in conclusion, we're performing at our center an increasing incidence of subtotal resection and supported by some of the research that we've done. We have an increased knowledge of tumor growth, but we've really shown some variability, and we feel like that's due in the large part to tumor biology, which is poorly understood. We, along with our patients, have a lower tolerance for poor outcomes. Even a house grade 2 is disappointing, where in the early part of my career, to get all the tumor out, and especially a large tumor, and end up with a house grade 2 was a success. Now, not so much. It happens, but we're not as tolerant, I guess, as you will, at a total resection on an MRI with the outcome that's less than favorable. Looking, of course, at more patient experience data, more patient-reported outcomes, what's important to the patients and guiding our strategy on these large tumors based on this. We're trying to understand our biases. We all have biases as surgeons to remember the good outcomes and tend to perhaps forget about some of the poorer outcomes and try to look at our data more objectively. And importantly, remember the golden rule. If you can look at all the data that you want, and you know that if you're intraoperatively, and you can use the golden rule and say, if this were me, and someone was operating on me right now, I'd leave this and call it a day. And if you can say that, I think that's the right thing to do, and use your best judgment in that regard. In the future, how can we get better? We don't really use any intraoperative image guidance, but perhaps that if this improves over time, it may play a bigger role along with intraoperative MRI imaging. Fluorescence of the facial nerve, I think, is a promising, may play a promising role. Intraoperative stereotactic radiation might one day be something that could be utilized for the remnant direct stereotactic radiation. And of course, postoperative improved techniques and improved, especially intensity modulated radiation. And then, of course, there's ongoing research for medications that may prevent tumor growth before or before surgery, and certainly of the remnant after surgery, and understanding things that we can do intraoperatively to that remnant that would keep it from growing, I think is the future. So it's a pleasure to present. I sure hope this technology is working and you're seeing me and hearing me and seeing this video. So thank you so much for the opportunity to share my thoughts. And of course, 10 minutes is not a comprehensive amount of time to discuss surgery for large tumor, but this is a nice overview, and I hope you enjoyed it. Take care. Bye.